Ready, so we're very lucky to have Dr. Gallagher. Thank you so much for coming so early. We appreciate it.
Yeah,
and I think this is a great topic for all of us, and we'll have some time for discussion.
Okay. Let me know when you're ready.
Okay, so caring for the mother and family of a fetus with a serious malformation.
So thank you. Glad to be here. This is kind of a emotional second home here. I very much work with all of you and appreciate your help. When Dorothy asked me if I would come, I said, of course, I would love to participate in this. And then I thought, what am I going to tell these people? I mean, what are we going to talk about? What am I going to tell you about things? Because we work together so often, and it's not like I have to tell you something new. And I thought, well, what do I do that may be helpful to you guys? And as a maternal fetal medicine person, this is what we do. And I thought maybe I'd tell you a little bit about our end of what happens when somebody's diagnosed with a problem. How do we deal with them? This is not to imply that you guys don't deal very well and very empathetically with our patients, and they love it down here. But we see them when they come back, and we deal with them from the beginning through. So that's what I'm going to kind of say. It says down the bottom there, I have no conflict of interest. I don't, except I'm very much a fan of you guys. I have more disclosures as we go along, but I'll show you that. So the objectives, and we're going to go right through the thing. How to handle a diagnosis, how we handle diagnosis of fetal problems, getting further information, and that's where you guys come in, help with decision-making, then supporting the woman and her family in that, supporting them during and after delivery whenever that occurs, and then how to approach planning for the future. So that's the whole spectrum we have when we see these patients of how we're going to support them. So diagnosis. Well, there is no greater time that I really regret and hate is at a time when I'm doing an ultrasound and see something on a mom who's come in for maybe a 20-week scan, and it's often she and her husband, and they're so excited, and I see something, and sometimes it's something that I know is going to be the end. And I have that one moment where I know it, but they don't. And I'm going to have to say something that's going to completely change their lives forever. And that time is probably about 5 seconds, and it seems like I sit there and talk with myself for about an hour or two. And finally, I just have to take a deep breath and say, I got to tell you something. And then we talk, and their life has changed. And the point is, yes, we've done that. Now the point is to support and accompany them during this change. I had a very interesting negative example of what not to do. Actually, I was up at Mass General, and I was ultrasounding with somebody who was very good, but I was just kind of standing there as they ultrasounded. The ultrasound finished. The person said to the patient, your fetus has a very serious anomaly, and I don't think it's going to live. You should talk to your doctor about termination, and walked out. So I'm sitting there, and I thought, holy hell, what am I going to do now?
I'm sorry, this is a sonographer, radiologist?
No, this is a radiologist, yes. And I thought, okay, all right. So that's not what we do, okay? So when I say gentle and very definite, I mean there's no ifs, ands, or buts. You got to tell them exactly what you think is going on and the severity of it, but in such a way that's not like what I just said to you. And it takes a while to do it. Show and explain. That's very important, and I think that's one of the utilities we have, although it's not the greatest thing for the 3D and 4D ultrasound, but it's great sometimes to be able to actually show them, because there's a lot of, they don't understand ultrasound. A lot of moms and dads don't see it, and you have to kind of bring it out for them. So I take some time to do that. And again, I try to give as much information about what this is and can we do something about it and what kinds of things it could be, and allow for an emotional reaction, because you just have to stand back and just let them go. Some of them will just explode. Some of them will go inside. And you realize that probably everything you said after, I think we found something very serious, is gone. They haven't listened to you at all. So you've said it, but now you have to go back and kind of say it again and realize you have to say it again and again and again. Repeat information as needed. And then they look at you like, what do we do now? So we outline a plan, and sometimes you have to have mom back for further discussion, let them see it. Sometimes they're not absorbing it right away. So here's my second disclosure, folks. I'm not a woman, and it's more an acknowledgement, and I don't claim to be, and I can't ever try to figure out what it would be like for somebody to tell them that a child who's growing inside them is now having a serious problem or is not going to live. And I've spent 30 years trying to get an idea of what that might be like, and I think I have some insight, but will never actually be able to feel that the same way. So I have tremendous respect for them, and I listen a lot to what's going on, and no two moms are alike as to what they need and what they're doing, and it's just a matter of, as the maternal fetal medicine person making the diagnosis, my job is to get them through that first part. Providing information is the next deal, and this is where you guys come in, because I often, with things that aren't something I can say, all right, this is what's going to happen, here's what's going on, and nothing is simple. And I tell my residents, too, never gloss over something like an isolated cleft. Oh, yeah, we can fix that, no problem. No, that's a disaster for a mom, because it's almost more of a disaster than if I tell them your child has tetralogy of Fallot and we have to do this, because nobody's going to see that heart when they're born. But they have to show their child to people, and they get very, so we have to care for them that way. I don't send every cleft to you guys, but maybe I should after that first case. Wow. So, yeah. We have to gather more information. So sometimes I see an anomaly and I'm not exactly sure what's going on, so that's why I do send to you guys. And so you're very much a partner in this here. And moms so appreciate when we send them to the experts here, because they feel like, wow, they're going to be in great hands here. So we really count on you guys to give information. So sometimes that comes from further ultrasound in our office. I have them back. I look at them. We spend a lot of time with these moms. Referral to you guys, to a fetal medicine center for evaluation. And what we expect from you guys, I guess, is exactly a repetition of what we do, is confirm or not confirm, or tell them exactly what's going on, give them a little bit of a prognosis, and where do we go from here? That's what they want to know. For instance, that first case we looked at this morning, my patients are going to want to know, what's this kid going to be like when he's born? What's going to happen? Are we going to, what's it going to look like in third grade? Are we going to have all sorts of, well, we don't know that, but boy, give as much as you can, and it really helps. And then we talk about it when they come back. It is really important for me to communicate with you to know what's going on, and vice versa. Please, Dorothy, you're great at this. Call me so we can know what's happening. And then when they come back to me, I know. There's nothing worse than having somebody come back from a referral, and you're like, well, what did they say? You don't know? It's like, who are you? What's going on here? So it's very smooth if I have the same information and can say, yeah, we talked, and this is what we're doing, and we're working together. And I'm going to use the word accompany a lot here, and there's a reason. We accompany them along this journey. It's up to us, I think, to stay involved with this mom. We're sometimes, for me, at both at Holy Cross and at GW, where I am, there are patients kind of, but there are sometimes patients referred into you from other docs. And you don't want to take their patient away, but you want to stay involved with this mom. And a lot of the docs who refer to you will say, help me. How am I going to take care of this person? So we try to do that. But you have to do it in a way that says it wasn't your doc great to send us here and to send us, you know, they're really taking care of you. And then plan for further action, and that's the next step that I'm going to get into. And I'm going to get into some very nitty-gritty stuff here. So
I just wanted to say that it helps us so much when there's been adequate preparation so that we're not dealing with that initial shock.
Oh, God, yes.
You know, because then the process only really starts here as opposed to, so we get parents that are better prepared than others. So it's so much easier to, and ease isn't why we want it to happen, but it's just that they can absorb the details much better when there's been that initial preparation. Some of them will say, well, they just said there's something wrong in the brain.
Well, there's various things go on, as you know, on the outside here. It sounds like we're in a club. But anyway, and people get diagnosed certain ways. Some practices will refer people to kind of general radiology things where the deal is, what's the mom's experience? Well, the sonographer got a funny look on her face and went and got the doctor, and the doctor said, well, you're going to have to talk to your OB, and says nothing to them, you know?
Yes,
so
I hate that.
Well, yes. My sonographers are authorized to tell people as much as they can.
Yes.
I think I see something here that could be serious. We're going to talk with the doc, and then we talk together. By the time they leave my office, they have an idea what's going on. Mm-hmm. But a lot of times, people aren't set up that way. Even people who have ultrasound in their office sometimes rely on their sonographer to say something's wrong here. Mm-hmm. Sometimes the doc goes in and says, well, I guess so, I don't know. And then they get sent to you, and it's like, well, what's going on? And that creates a lot of resentment for the referring physician sometimes, because they're like, well, why didn't they tell me that? What's going on? Do they not know what they're doing? So if they come through us, we hope that
part again, Mike? A resentment.
The patient will often say to me is, why didn't they tell me this at the office? You know, why?
Yeah. Okay, all right, I got that.
And you want to say, you know, the truth of the matter is that they didn't understand. Mm-hmm. They knew something was wrong and just sent you, but you can't really say that because then it's like, well, who are they? Mm-hmm. So you say, well.
Or like even with that 15-year-old going, well, why did they just pick it up? You know, and they're, and I said, you know, it's because often it doesn't sell, but no one told her that since she was getting.
So we make the point.
And that's a whole other thing, and that's a whole other thing about how I think we kind of differ in people all over the maternal fetal medicine world here, kind of differ in the way we deal with people.
So just real quick, you said that you give your sonographers, you've given them the liberty of using some sort of phrase with the patient that kind of keeps them into. So what is that? I mean,
well, they cannot. First, if they discover a fetal demise, they will say, I can't find the fetal heartbeat. I'm going to get the doctor. So, you know, it isn't like just walk out of the room and they're still like, oh boy, what sex is the baby? They're nervous, and then I come right in. First, I will follow up on with our sonographers on just about every patient. So I'm coming in. Sometimes they gasp when I come in the room with something wrong. No, I'm just coming in. I like to look at it. But our sonographer can very much say when they find something, gee, I'm a little worried about this heart. That's what they'll say. Okay. Not say, oh, I think your baby has tetralogy below. No, I'm a little worried about this heart, and I'd like our doctor to take a look at it. So it's not like they just walked out of the room with a sullen face. They've said something, and they've prepared them a little bit. So when I come in and say, hey, I hear we have to look at this heart a little bit more, and then we go in, and then if it's something serious, they come down in steps, so it's not like slap in the face, okay? And by the time they leave the office, they know kind of what's going on and a little bit of prognosis, and I'm going to send them down here because I want somebody to really look at it. So that's really us. That's on us before we send it to you guys, I think, okay? Okay, like I said, now we're going to get into nitty-gritty. They've seen you, they've looked at, they've gotten an idea what's going on, and then they do come back to us. And we do like them to come back to us for further care. Decisions. So how does a mom wish to proceed now that she knows something is going on? We perhaps provide more information And it is so good if I know what you think it is, because if I don't know what it is, I can go look it up and look like I knew what it is. No, honestly. Honestly, that's what we do. I mean, people know how to handle things, and we know how to handle things, but I don't have everything on the front of my mind. Sometimes I have to go back and look it up a little bit, and then it's like, and
you're not alone, Mike.
Does it? Well, no, I know.
But, I think that we now have capacity to do that at point of care, which is hugely valuable. You say, I'm going to look it up and give you this information.
Very much so.
Which is very valuable.
And sometimes you say that to Mom, too. You don't pretend you say, look, I got to look at this, but I kind of know what it is. Boy, do they really appreciate that, too. There's a mom who said to me one time, I think I scare my obstetrician, and that really bothers me. We should be not Superman, but at least somebody who kind of like, okay, we know what this is, and we can help. So we listen, we inform, we support. Those are the three important things, I think. We really have to listen and then providing support. So we're not just the information, the cold information that I gave you, the example of there, my experience in Boston, but we have to do that. And then I'm going to use that word again, accompany mother along whatever path she chooses, okay? All right, nitty-gritty. I'm going to give you another disclosure here, okay? My background, I'm Catholic. I'm not just that's where I go to church, but I actually have a degree in theology. I do active theology. I read. I dialogue with other theologians, and I teach medical ethics at Georgetown once a semester. So it's something that I'm very active about. I absolutely deplore the dialogue. No, there's no dialogue. The noise in the country today about the decision whether to terminate or not to terminate, pro-life, pro-choice, I hate it. There is nobody more pro-life than our moms who have these problems. And there's nobody who regrets that they have a choice to make. So it's an insult to them to start making pre-choice, whatever like that. But I wanted to tell you that background because how do I approach moms who come to me trying to make a decision what to do? So let's say they decide to, that termination. First, do I counsel for it? I sure do, because the thing is, first, legally, we have to. Secondly, the approach I take is one of going out to meet people where they are. That's if you follow anything in the news about the current things in the Catholic Church, that's what the Pope is saying. Go out and meet them where they are. Don't stand there with rules saying this is what you have to do. There's a profound change going on, and you may not know if you know the Catholic Church. It's profound. Something as simple that was in the news and everybody could read it and say, oh, that's interesting. The Pope giving individual priests the power to hear confession on abortion and forgive it. It used to be the bishop had to do that. Can you imagine a poor mom who felt she had to do this, has to go down to the bishop and say this? Now anybody can do this. Any priest can completely bring them back in because we're going out to meet them. And the word accompany is the one that's used. We're to accompany people on their journey. Yeah, we have certain values, and I see those values. I see what they are. I see why they say certain things. But I think we have to meet people, and believe me, that's how I approach this. I go out to meet them where they are. So I kind of figure out what do you want to do? What's your thoughts? Well, we're thinking that this isn't something we can handle. We're thinking of termination. Okay. So what I do is give them information about that. I give them information about alternatives. What if you didn't? This is what you have. This is, because sometimes they don't have information about how this is going to be. Most especially, there are people who want to terminate for clefts. And I'm like, well, let's think about this. I know this is going to be rough. But then there are people who have wildly awful brain lesions or trisomy 18 or something like that and say, you know, this is where we think we need to go. Okay, information about the procedure. We're very, in the GW practice right now, there's a family planning service that is very good and will provide very, very sensitive and valuable service for terminations up into the 20-some weeks. So when patients go there, they come back and they say, oh, they were so gentle and nice and understanding. And then referral. I don't do terminations myself, but I know to whom to refer, who they will be handled very well and very sensitively. Financing is a huge thing here. Okay, so anybody with the government can't finance these things very well. If they're working for any of the church organizations, that's a problem. And that's a little bit of abandonment, I think. But anyway, we try to work around that. I'm not going to go into detail there. Support, the bottom. Support, support, support. Okay, I actually may not agree with the decision to terminate. I may think it's a little bit, wow, I wish they would keep going. This could be. But I have to support mom, and that's the deal. This isn't the time to have a discussion, either theological or whatever. It's the time to kind of support, give information, figure out where people are, and try to be with them. Accompany is the word. Continuation. Okay, I'm going to go back to termination a little bit later, but continuation. So people who want to continue, either because it's not that serious, it's going to be a problem, but they're going to have to deal with it, or it is that serious. People who say, yeah, I got a trisomy 18 or trisomy 13 or somebody with a mom with holoprosencephaly, I cannot terminate. I just cannot do that. Okay, fine, we'll be with you in continuing this pregnancy. What's it going to be like? How are we going to follow up? Who's going to follow them? The error that we try to, and it still is some practices, is, well, why are we seeing these people? It's only going to be, it's a termination or a terminal event, so we only have to see them every once in a while to make sure they're not getting preeclamptic or something. No, we actually have them in and do ultrasounds and show them their fetus, and sometimes it's the only time they're going to see this fetus alive. We've had such elaborate things as being asked to take 3D pictures. We do. I have a mom who says it's still on her dresser, the 3D picture of her baby that died. The most elaborate thing I had, but I did it, is somebody came in and actually said, can you kind of measure this baby in your term, like various measurements, and they made a little garment for this baby after it was born. Oh. That killed me, let me tell you. Yeah. But that's the kind of accompanying we want to do with people going on. And by the way, the kind of accompanying we do with people who are not going on, supporting what they do.
Dr. Gallagher, can I ask, one of the things that I struggle in this issue is making sure that people understand the severity of something, because I find that there are two features of my clientele. One is a distrust of medical advice or medical information, and a sense of magical thinking, that not only are we wrong, but it's going to get better. And how do you manage that when you're working with this issue?
It's easier when there's a big abnormality. You can show them because we do the 3D and say, you see, that's still there.
Right.
And I keep, it sounds, as I said, the support, it sounds like it's all like, oh, let's see this baby while it's still alive. It's also reinforcing it. You're not going to see this baby. This is not going to work. This baby has this. And I don't hit them on the face with it every time, but we do talk about, but remember, this is a very bad thing, even though it looks good. And it's a way of, if they're continuing, it's a way of kind of, by the time they're ready to deliver, they know what's going on, hopefully, when I'm doing this. So, yeah.
They know it in the frontal lobe, but whether they know it in the hippocampus, I don't know.
Some of them will know it very, very down inside, too. Let me tell you.
And I think that's where, like, MR can be such a powerful tool.
Very much so, very much.
Because, I always feel that, here they're meeting so many doctors, they don't know who we are, they don't trust us, and I think the images empower them. They no longer have to depend on these strangers to tell them what they're seeing. They can actually see the images themselves and understand why we're so concerned.
Good example. At Holy Cross, we had a patient who was came in just kind of last minute, no prenatal care, ended up having holoprosencephaly. Baby born. They were unable to let go of it. This brain is going to grow. I know it is. It's going to grow. That, give it a chance. And if that were a patient we were following for a while, we would constantly be looking at this head and say, see, this is, it looks beautiful, but there's just nothing there, and hopefully lead them very gently along that road of, what are you going to do right now? How are you going to spend some time with this baby after it's born and not have tubes and everything placed in it and everything else?
So we do
time as opposed to the element of surprise.
Yes, very much. Huge. Yeah, because if it's a surprise, they're not going to take it. But you give them a whole time to accept. And
so we started doing, sorry, Mike, and we've started doing some repeat MRIs, which a lot of people will say, how's it going to change your management? And that's the old question that neurologists always face.
Yeah.
But I think, particularly if you think that subsequent development after the first consult is likely to go awry, being able to show them, this is what, we show them a model. This is how the folding is going to happen in a normal baby, in a baby that doesn't have your baby's problems.
See how bad it is.
And then when they come back, you say, remember I told you the folding would look like this?
Yeah.
It doesn't. I think it's very important.
And for people who count money, I can make a financial cause of this, too. Even all of the, if we do serial ultrasounds, or even your MRI, it's going to cost less than 5 or 6 weeks in the NICU because they won't let go of this baby. So for the bean counters, you can hand them that too.
Good point.
Okay. I'm going to move along here. So after delivery, either way, when I say delivery, it could be termination too. And you have to stay informed. So when I say stay informed, I want to know what happened. If they didn't deliver where I am, or I didn't deliver them, I need to know what's happening. If they had a termination, what was your experience like? What happened? What does the baby look like? What's going on? Encouragement, empathy, certainly, and encouraging them to stay in the moment. A lot of times people are going to say to them, oh, well, in the future you can still have a baby. It'll be fine. You can have another one. The worst thing, one mom said to me, the worst thing I felt like if I had something sharp, I would have stuck it in their face, is what she said, is they said, you're young, you can have another one. She said, I can never have this one again. And that's what you have to. So stay in the moment. Mourn. Encourage them to mourn. You've got to mourn this. This is a loss. You've got to go through it. Some people will take and just talked to a family yesterday that took and had their child cremated. We have funeral homes that will be very, very sensitive to that kind of thing, and they're going to go home and bury it in their hometown and all of this. This is so important for that end here to say this happened and healing now to go on to the next one. Future planning. When they're ready, we provide information, we discuss risk, we provide support, and we bring them back for review. And sometimes I'll bring them back a few times after when they're ready. I tell them, look, when you feel like you want to talk about maybe the future, fine. I assure them, this is where I had to assure somebody yesterday. I didn't want to get this you're young talk, but she said, well, I'm getting older. We should do this right away. I said, you're 35 years old, really? A month or two, not going to make a difference. And it really made a difference to her. She's like, really? Yes. Just do this, and then we'll talk about it a little bit later. So that's kind of what we do. So the key word is this. Again, it's the word that's being used in our church right now. Accompany people. Be with them. You're not necessarily, maybe they're not going the way you would like them to go, but be with them. And that's so important because one mom said to me, I felt so alone after all of this happened because they got thrown out into nowhere. It's like, oh, yeah, this happened, and you went here, and you went back, and their obstetrician didn't know what to do with it, and they were like, and to accompany them and actually sit there and talk to them about it and listen. That's what we do. So that's part of it. I'm going to hang there because that's the half hour. Okay.
Well, thank you very much. So for us, I I can only speak for myself. I really believe that parents need to see the demon, the issue, to begin the healing process and not imagine it. As I said, we sometimes bring them back to repeat that. I'm a little less confident that that we can justify bringing them back just to go over things again.
I think from our point of view, we can do that.
Yeah.
With help from you guys. Sometimes, however, they need to hear it from you, in which case we'll say, all right, maybe.
So from a brain standpoint or a neural standpoint, and I say this to parents, it's like, I'm going to try and describe for you what your life is going to be like with this baby so that you understand, but I've got one shot at that, right? And I'm not sure that the MFM or the OB, unless they have neuro training and have seen children with cerebral palsy and all of that, that they are going to be able to paint that picture. And should it be repainted, as you mentioned, to just sort of work with them. I mean, that's a lifetime's education in one session. So that's sometimes discomforting to me, knowing that, well, first of all, there's their original decision, and have I given them enough information that they can obviously, there's no informed decision. It's better informed than before they came, but it's not truly informed. Thank God I haven't gone through that personally. So our role in that sort of ongoing, we really try to close the loop from fetal to safely on the ground and in the best possible condition. But our role in the latter part of pregnancy, something that I struggle with sometimes. I feel like a family doesn't, you don't want to beat them on the head with it because they're...
No. But a lot of it, that's up for us who are taking care of them every day. I'm not sure that's what I want from you guys. I want the initial...
We do have a magic bullet. You know, I mean, our counselors just do a wonderful job.
Yeah, you guys do help. You really do. And if we can segue off you,
we'll go back and call them. And then alert us if, something is wrong with you guys.
And alert us, too, please, if you uncover something that we need to talk about, because we want to be with these people.
I did want to say how powerful it is to have a long-term relationship with some of your families, which we don't have. I mean, we have some families that come back to follow up, but one case that particularly struck me was it was a family, Irish Catholic, and they came with this like terrible high drops. I'm like, oh my God, what are they going to do? And I called you, and you just were like, okay, they kind of know this, they're going to be continuing no matter what, and it's okay. And I would have gone down such a long road if I hadn't spoken to you before I walked in to that room, because I would have been completely on the other way. So I think, your group in particular is very helpful, but we have to remember sometimes that our referrers do have a lot of history behind there, and it's not necessarily the notes, but before we have to go and talk to them.
That's why I think it's good for us to call you beforehand. I often give you a case and say, somebody's coming, helpful. Here's the deal.
Yeah, it's really
because this kind of care is what we have to do. It's just, I want to keep them the feeling that they're getting, it's all one care. It's not like you're bouncing here. It's one care. And
the partnership.
So I do appreciate that. And say the truth, what you think, and we'll deal with what's going on. I deal with a lot of families who are a Catholic tradition, and yet they end up terminating, and we end up doing a lot of discussion on that and how, and they learn a lot about things, how simple things are not, and how they once thought they were simple and they're not. Most of the discussion today in and outside the church on abortion has no idea what they're talking about as far as our people. They have no idea. think the average person who's railing against it thinks that there's some person who's saying, oh, I'm too busy to be pregnant. No. There are people who desperately want to have this child, and somehow it's taken away from them. So we're trying to inform people of that, by the way, and anybody who will listen, we don't do so. So teamwork.
That was outstanding.
Thank you.
Thank you very
really
much.
Appreciate your help, and that's how we work together.
Any other questions? It's interesting we have one of our new stenographers with us. We do handle a little bit differently here because we have gotten into trouble at times when someone has said something and either they said they thought there was something wrong and then it turned out it wasn't, and we've gotten letters of complaint from the families about that. Or vice versa, that said, oh, everything is fine, and then I walk and go, well, there's this, and that.
Yeah.
So you do have to be, very careful, and we have grappled a lot with when there's been a fetal demise and how to handle that. And I think it's just a very tough situation, and it's been even tougher because we've done a few fetal MRs where it looked like it was a demise, but I really wanted to get a Doppler to confirm if it was with them.
Yeah.
So we're holding back. I feel badly about it. The few families that I kind of talked to said, I really apologize that we kept this from you for a few minutes. I just wanted to get some information. And they've been okay, but I think that's a very, very tough situation.
I think if you don't have to tell them everything, but just realize that, whoa, there's a little question here. As opposed to like, oh, everything's great, see you later, I come in, and then I come in and say, oh,
yeah. There can't be that complete disconnect.
Yeah, there has to be something. I don't know.
Yeah.
How do you feel about that?
It's definitely a fine line in this walk, and something we learned from the beginning too. Like, we're not diagnosing, and we don't really go into statistics for patients.
No, please go ahead.
Sometimes you can't sort of hide that there's something going on.
Yeah.
Right.
Sometimes they're glued to the screen. They're looking for the heart rate, and they don't see it.
And they don't see it, and you can't lie to them and say, oh, well, everything's fine. Our people usually say, I'm having some trouble seeing the heart here. I just need to. And moms know what that means. Uh-oh. And sometimes I can come in and say, sometimes it is trouble. And I say, oh, wait a minute, there we are. Somebody did that in very early gestation the other day, and I came in and I said, oh, here we go. And I'm like, oh, okay, all right. But sometimes it isn't, and they're prepared either way. They're immensely relieved.
And I've had a few families that come to me. I mean, literally, these mothers have come back 20 years later or 20, 30 years later. They remember that day, and they remember whether you did it well or not. And they're like, they're so angry at the person who they just walked out of the room. They didn't say anything, and this is like decades later. They're harboring this anger, and
that's the moment that changed their life.
Yeah,
that's why, and it has to be handled very carefully.
Tightrope,
Yeah.
I think if they feel that empathy or the concern, you'll be okay. I think it's just that the coldness or that discomfort that they will react.
My concern with my sonographers is they don't feel like they're out on a ledge somewhere alone, that they're with us.
Yeah.
And also we tend to talk a little bit afterwards about how, you okay, what that was, because that's bad for you guys too. I mean,
it's traumatic.